start our viva cases. Is mainly pediatric. This patient is 20-year-old male patient complaining of abdominal pain.
Okay. Shall I request control?
I will I will scroll for you because most of you shift to the answer. I will
Okay.
scroll.
Okay, fine. So here I'm provided with the contrast enhanced. I think these are the non-contrast axial CT abdomen images of a patient who has presented with lower abdominal pain. Okay. In this abdominal images, I can see that there is a
Stop me.
calcific density. Hello?
Yes. Stop me at
Yeah.
the slice of interest.
Yeah. Okay, so I'll just quickly go through the entire stack of images before giving my final comments. Okay, I can see that in the lower abdomen. Uh, okay, fine. So I'm going to the last cut, uppermost cut. Okay, scrolling back. While scrolling, I noticed that the bilateral kidneys are enlarged, and I can see there are multiple fat density lesions noted in the bilateral kidneys. Okay. Uh, I'm just going down to look for any other pathologies. I could notice that there is a calcific density lesion as well noted in the noted speck of calcification noted in the right lower abdomen. So
Okay.
in my routine practice, I would like to have a look at the post-contrast images, and I can also see that there is some mild fluid and also noted in the peritoneal cavity, which appears to be hyperdense fluid noted in the peritoneal cavity. So in my routine practice, I would like to have a look at the post-contrast images to characterize these better. These bilateral renal lesions, fat-containing lesions, are in keeping with bilateral angiomyolipomas. So I would like to, however, the liver appears normal. I'm not able to see any angiomyolipoma in the liver. There is Dr. Rami, could you please show me the upper bigger mass, the
This one.
bigger. Yes. So yes, I can see that. Okay, there are tortuous vessels also leading to this. However, I'm not able to see any cortical breach, any no associated. Yes, no associated perinephric collection noted. Could you please scroll down, please?
Down.
Yeah. Please come down. Okay. However, there is no evidence of any perinephric path standing noted. Coming down, just want to reach the. Okay, okay. So I'm just want to have a look at the um, calcific density focus, which I noted in the lower abdomen. May I have a look at that focus? I would just want to confirm that whether it is not in the appendix. I just want to confirm whether it is not appendiculate. I'm just really concerned for that. If it is a cause of pain. Hello? Yeah. Okay. So I'm just trying to trace
Yes.
that.
Yes.
Uh,
What do you
I'm not.
want?
I just want to see. I just want to. Yes. Okay. I think yes. I think it is just in. It is inside some bobble loop only. Okay. So, but however, I can see that there is some fat stranding noted as well in the peritoneum.
What's
Okay.
your diagnosis?
This is in bilateral angiomyolipoma in keeping with tuberous sclerosis. So, in my
Yes.
routine practice, I would like to have a look at the coronal images as well. I would also check the lungs to look for any lymphangioliomyomatosis, and I will also check the bone windows to look for any sclerotic focus in the bone. However, I'm not able to see any frank perirenal collection as which could be a source of I mean which could represent any perirenal hematoma, which is a potential complication. So may I have a look at the coronal images, please?
Why you?
I just
Why
want
do you want?
the
Why do you
patient
want
is.
Cronin?
I just want to see because I think yeah, I can see that there is some perinephric collection noted. So I think one of the angiomyolipoma has ruptured, which has led to the perinephric collection, hyperdense
So
perinephric collection.
what's your final diagnosis?
So, but my final diagnosis is this is a retroperitoneal hemorrhage, which has extended to the peritoneal spread as a result of ruptured angiomyolipoma, which as a result of one of the angiomyolipoma which has bled. This is an emergency. This will need urgent referral to the on-call surgical team as well as interventional radiology for urgent embolization.
What else?
I would like to see the lung windows as well to
What
look for
else?
any.
Don't worry about it. What else?
I'm really worried about the calcific focus. I am suspecting could it be a appendicolite in keeping with appendicitis. In my routine practice, I would like to have a coronal images as well, just to see its continuity from the base of. I mean, whether it is in the appendix or it is outside the appendix. I just wanted to confirm that.
What do you think?
Uh, Now I think that yeah, there is some herniation. Uh, okay,
Much
yes.
more easier for you to detect the connection or the anatomy for the appendix, axial or coronal.
I think, yeah, actually, in my routine, I use both coronal and the axial images. I use
So what's
both.
your final diagnosis?
Mm,
And what is your next step, please?
uh, I'm not able to see that. Please, could you please scroll that in that region once?
What's your final diagnosis?
Fine. So, okay, yes. So I think that this is in keeping with appendicolith in the dilated appendix. I mean, yeah.
What's your next step?
So the patient is having appendicitis as well. So this patient will need urgent referral to the on-call surgical team
What
for.
else? What else?
The patient has to be started with, and I think ultrasound correlation,
No,
uh,
what else?
correlation with the inflammatory markers, correlation with the inflammatory
What
markers,
else?
genetic counseling has to be advised for this patient to
What
look for.
else?
I would also screen the brain to look for any spectrum of tuberous sclerosis. Like, yeah, I would like to see the brain to look for any
What
cortical
do you
tube.
think?
So here I can see that there are yes, the gyri are thickened, which is forming cortical tubers. I'm just looking for subependymal nodules. Yes, I can see that there is subependymal nodule noted in the left lateral ventricle. I'm also looking for, okay, but there is no subependymal, I mean, I cannot see any subependymal giant cell astrocytoma. There is no hydrocephalus. So, but yes, this
Which to which pathological group does the tuberous sclerosis related?
it is phakomatosis.
What do you mean by phacomatosis?
Phakomatosis has a problem related to the brain as well as something related to the eye. The patient also has some eye problems as well as something
What
related
else?
to the patient also has retinal hematomas. The patient,
Brain, one second. You mentioned brain, eye,
ye-
and what else?
yes, and also the skin manifestation, cutaneous manifestations.
What is the most important to be told about this patient
About any
holistically? Holistically, you see to examination for
the
this
pe-
patient.
the
Hmm.
patient has complaint of epilepsy, adenoma sebaceum, and low intelligence. The patient complains of epilepsy,
What is
low.
the most important recommendation you will mention in your report?
The patient will need serial MRI, like the patient will need one yearly imaging to rule out any development of subependymal giant cells astrocytoma, which can cause hydrocephalus. Right now, the patient is not having any subependymal giant cell
What
astrocytoma,
is this?
but
Dr. Amiga, one second. What is this?
this is an angiomyolipoma. This is a giant angiomyolipoma, which is 4 centimeter in size, approximately more than four
So,
centimeter. So this has
so
propensity. I think that there is some retroperitoneal hemorrhage as well. I was
no
suspecting there.
hemorrhage. See. No hemorrhage, no hemorrhage.
Okay, then
But
this patient will
yeah,
need intervention radiology referral because more than 4 centimeter they are have propensity to rupture and they should be embolized.
thank you so much. This is the most important to be told besides the appendicitis. about this patient because he has one, two very large angiomyolipoma and very vascular. It may be a source of fatal bleeding. Fatal bleeding. So it is important. This case was very nice. Why? The patient has very, very obvious and very common pathology. Bilateral angiomyolipoma. Number one, you must rule out any associated mass or angiomyolipomas or cysts in the liver, like this one. Okay, or this one. This is it. It was this one hemangioma. And besides that, I told you many times before when the examiner give you very easy case, expect something, especially not the first case. The first case usually like this, very easy. But if this is the middle or the end case, think about the complaint more. Look here. If you look here, you will find appendiculus and collection and the tubular structure. All this is the appendix. How to detect the appendix? I think the axial is more easier. Why? Why? This is the terminal ileum. This one. This one. Follow it. Okay. Posterior to it is the appendix. Follow? Yes, I think the structure we are talking about is the appendix. Okay. This one. Where is the annotation? This one. Look. See, behind the uh, ileocecal junction. Okay.
Yeah.
So don't ask too much in MBR. In MR examination, you have the right to ask for post contrast, for flare, for diffusion, because it is a must. But in CT, they like too much to work on axial because axial is the origin of CT. Okay. I
Yeah.
I I tell you something very important. Don't be panic when angiomyolipoma is presented in the exam in a typical scenario. Why? In my first viva, the examiner gave me two sequence in and out of phase only, and it was very small signal drop in both kidney, very small bilateral. I was confused. What is it? This is not the usual presentation for angiomyolipoma, but finally it was angiomyolipoma. Okay. Some cases in the exam are presented by typical sequences or sorry, by atypical sequences or atypical. So it was a case of acute appendicitis on tuberous sclerosis patient. Thank you so much. Do you have any question, Dr. Amigo?
No, no, thank you. Thank you.
Okay, thank you. You did very well. Next candidate.
Thank you.
Assalamu alaikum, sir.
Salam. Doctor, this patient has fall down, and so he did this X-ray. What do you think? Go on.
I have been presented with the frontal X-ray of a pediatric patient of lower leg, and the patient presented with trauma. And the most striking abnormality I can appreciate is some periosteal reaction along the tibial aspect, along the medial tibial aspect of the shaft. And I can see that there is mild soft tissue swelling over it. However, there is also some geographic lytic lesion, uh, moth-eaten type lytic lesion with wide zone of transition noted just beneath this shaft within the medulla at this site of the tibia. And I can see that this periosteal reaction overlying it is laminated in appearance. And I cannot see any cortical break here. In my normal practice, I would like to zoom that and change and window it. And however, looking this, I summarize that this is likely an aggressive bony lesion with differentials
Yes.
of Ewing sarcoma and osteomyelitis.
Mm-hmm. So, what is your next
Further,
step?
yes, further, I would like to advise the MRI of the patient to see the extent of the lesion and to see the any skip lesion and the involvement of the overlying neurovascular bundle. So I have been presented with the MRI of the same patient, axial section of the bilateral legs.
What do you think?
Yes, in this provided image, I can appreciate that on the patient has, so can you scroll a little bit? Yeah, I can reappreciate that there is periosteal reaction with underlying bony marrow changes and involving the tibial shaft, distal tibial shaft diaphysis, and there is also aggressive overlying soft tissue swelling, and there is also mild soft tissue edema as well. And this lesion is only on the right tibia. So I confirm my finding that this is an aggressive lesion.
Yes.
That
What is
is,
your next step?
I would advise the patient chest X-ray to rule out any metastasis. I would also advise the patient, as the patient might have some metastasis, I would also advise the whole, to see any skip metastasis, I would advise the whole of the bilateral leg X-ray. Sorry,
Do
leg,
you,
yeah,
do you,
X-ray as well.
do you remember the age of patient?
Yeah,
What is
it
your
was a pediatric
differential
patient.
diagnosis?
My different diagnosis is Ewing sarcoma,
Yes.
and yeah, it is an aggressive lesion, bony lesion with periosteal
Okay.
reaction. Yeah.
If I told you the patient came after 1 week complaining of severe headache and bilateral upper limb weakness, what is your next step?
Sorry, sir, headache and bilateral lower limb weakness.
Yeah, limb weakness. Yes.
Mm,
What is your next step?
I would like to see the any involvement in the spine as the patient is presenting with bilateral lower limbs weakness and headache,
Okay.
neural symptoms.
He did. He did this exam. Could you have a look,
Mhm.
please?
I've been presented with the MRI brain
The
axial section
examiner,
of the same patient.
see, see,
Yes, sir.
see, see, to make a gentleman agreement, the examiner only have this sequence, and you should comment on it. Okay? Don't look at the left list. This is the only available sequence. Go on.
So can you scroll for me again? I'm sorry.
Okay. What is the name of this sequence?
This is a SWI sequence.
No. See, the rest of
This is
this
yeah, yeah,
sequence?
diffusion restriction.
Yes. Yes. So what you think?
I do
What
not
do you
find
think?
any area. I do not find any specific area of increased.
Are you sure? When the examiner gives you something, it is in the sequence must have some finding, especially MRI.
Bilateral cortical increased area of restricted diffusion
Yes. What
in
does it
the
mean for
bilateral
you?
cerebral hemispheres.
Yes. What does it mean for you? What does it mean
There
for
may
you?
be some metastasis going on in the head.
Which type of
leptomeningeal
metastasis? Excellent.
leptomeningeal metastasis.
Excellent. What is your
I would
next
further,
step?
I would like to confirm it on the post-contrast sequence. And
Okay. This is the post contrast. Is it confirmed or not? Hello?
yes, I can see. Yes, sir. I can see leptomeningeal enhancement
What else?
bilateral, the bilateral cerebral hemispheres.
What else? Hello?
Yes, sir. Can you scroll again?
Yeah. My voice is clear?
Yes,
I
sir.
see.
Yes, sir.
Yeah. What else? What do you think?
There's increased vascularity, and apart from that, also in the basal cisterns, there's increased leptomeningeal enhancement, and also in the
Okay.
suprasellar cistern.
Yes. What is your next step?
I would immediately inform the referring physician,
What
and I
else?
would, um,
Oh, what else?
yeah,
In any patient with leptomeningeal metastasis,
I
you
would see the
must
neurospine
do.
exist. Yeah,
Yes, this is a must.
to see any metastasis there as well.
Which sequence do you want? Ask only for one sequence.
I want a sagittal post-contrast sequence.
Okay, but the examiner told you this is the only available sequence.
Right, sir. Sagittal
What
star
is your
sequence.
mm,
I
what
can
is the
see
name
that
of the
there is,
sequence?
sir, star sequence.
What's your diagnosis here?
I can appreciate some irregular nodular dural enhancement along the spinal canal.
Ask for control, please.
Yes, sir. Sir. Yes, sir. Requested.
Did you ask? Yes. Show me where exactly.
Sir, I'm talking about this region.
Your mouse is not move. Hmm.
Um, can you see it, sir, now?
No. Ah, yes.
Okay,
Which one?
sir. So anterior to the cord at the level of, yeah, here. Sir, I'm talking about this
This line
irregular
only?
nodule ligament. This one. Yes, sir.
Okay. Do you have anything to tell me?
I would like to see that in axial section as well to exactly.
Okay, see? Leave the mouse once again. If you told this is a stair, correct?
Sir,
In a stair, should you see the CSF of intermediate signal like this?
no, it
Or
should be high signal.
so all of this, see, all of this are leptomeningeal metastasis or meningeal metastasis, all this. Okay,
Right.
and all of this also. See, my colleagues, sorry, I'm trying to expect the worst scenario. And by the way, it may be one of the scenario of viva that the examiner give you very unhelpful sequences, and you should get the answer like here. This is stair, and really it is confusing. But all this, see, from here to here, all this thickness, wow, maybe 2 cm along the lower lower part of the ceca, anterior and posterior, is drop metastasis. Okay, my colleagues. Thank you, doctor, so much. What happened here, my colleague? Case, very long case. Start from X-ray, and the examiner give a um, very misleading history, trauma. But there are very reaction and sclerosis here. Then finally we end by drop metastasis. What happened? It was an Ewing sarcoma. Okay, this is the mass here in axial, soft tissue mass infiltrating the bone marrow, distracting the bone, and extending into the surrounding muscle. The best to be seen is the sequence, I think, sagittal stair, this one. Okay. Ewing sarcoma is not a familiar to cause left meningeal metastasis. Doctor, what is the most common in this age group or in pediatric age group tumors that cause leptomeningeal mets?
The
Hello?
posterior fossa tumors, yes, sir,
Yeah. Which posterior fossa tumor?
like ependymoma, medulloblastoma, and
Thank
also
you.
pineal gland tumors.
The examiner gives the candidate diffusion. What happened in the beginning of diffusion? We didn't use this one, by the way. We use the higher values. We use the images which the CSF is dark. This is not our diagnostic images. Look here, this one, as well as, as long as the CSF is dark, the normal sulci should be dark, either in flare or in diffusion. Take this very important home message. As long as the CSF dark, if this is a normal case, you should not see any signal here, either in flare, stare sometimes, or diffusion. So there are restricted diffusion which will ensure in EDC. Look at the EDC. You didn't ask me for EDC. Okay. See the sulci is very dark. Sulci is very dark. This is confirming the restricted diffusion of the sulci. So it is leptomeningeal drop metastasis. Then I give her a complaint about the cord. I think, in my opinion, you should, before the examiner ask you for what is your next step, or the patient has bilateral hemiparesis, you should tell him, doctor, I will do whole spine MRI. What happened here? What happened here? This was the stair, and all of this was leptomeningeal thickening of the cecal sac. Thank you so much.
Thank you,
Next
sir.
candidate. Ewing sarcoma with leptomeningeal drop metastasis. Next candidate. Hello, Dr. Miga. Who is the next candidate?
Yes, I think Dr. Dr. Amit. Dr. Amit. Hello?
Okay. Candidate number 4.
Yeah, Dr. Mohan. Dr. Mohan, are you available? Hello? No one is answering. Okay,
I'm
Dr.
candidate.
Khalida.
Okay, I'm candidate 5.
Dr.
Yes.
Khalida, you can please go.
Okay. So this is X-ray chest frontal projection of a 40
Yes.
years old female patient. So here I can see that there is a well-defined homogeneous opacity which is projecting over
Yes.
the left lower zone. It is showing well-defined lateral margin and merges medially with the mediastinum, and I can see hilar vessels through it. So hilum overlay sign is positive, and I cannot see a hard border separately, so it is simulating the left hard border. However, I can see the descending thoracic aorta and aortic knuckle separately. So it is basically anterior mediastinal mass. I cannot see any differential density in it, and there is no calcification. So in summary, the findings are of anterior mediastinal mass. My differential in this case, there is no further lesions in the both lung fields. There is no pleural fusion. The rest of the bones appears unremarkable. So, and the overlaying bones over the mass also unremarkable. So in summary, the findings are of anterior mediastinal mass. My differential in this case, this could be lymphoma. Other possibility could be a thymoma and lymphoma, thymoma, and teratoma is less likely as this patient is old age, 40 years. So I'll further evaluate this patient with CT chest with contrast to look further characterize this lesion. So I've been provided with CT axial post contrast in the arterial phase. So I'm just going through the images first. So I can see that sir, yeah, can I see the area of interest? Yeah, so here I can see that there is a well enhancing mass is seen in the right anterior mediastinum. It is showing it is abutting the aortic arch and ascending aorta. So on my routine practice, I will further can you sir please scroll the images so I can check its connection with the this is um this is ventricle, this is left ventricle, right ventricle, and the match is also showing enhancement, so it seems to be in continuity with the pulmonary trunk. So in my routine practice, I will check the coronal images to confirm this, or this is just yeah. So I can see there is aneurysmal dilatation of the atrial, left atrial appendage. I will check the clinical history of the patient and further evaluation of the patient with echocardiography. I cannot see any filling defect to suggest thrombus in the left atrial appendage.
Oh,
So immediate.
what? Yes. What's
So I will
your
convey the
final
finding
diagnosis?
to. So this is left
Final.
atrial appendage enlargement. So I will
Mm.
convey the finding to the referring physician and further chest MDT discussion and cardiology consultation is suggested in this case for further management.
Okay. What is your next step?
So echocardiography to look for the presence of any embolism. If the patient have any history of congenital heart disease, so this may be due to this. So urgent cardio thoracic surgeon or cardiovascular surgeon recommendation for further evaluation and management.
What is the most important about this patient?
Patient may develop thromboembolism.
What
So
else? What else?
there is a patient may have pulmonary hypertension. So I will also look lung window to check for the
And what about this?
presence of a pulmonary. Yeah, here I can see that the left lung, the left kidney shows a significant dilatation of the pelvic ileal system, and it is of hypertrophy. So this may be due to hydronephrosis.
Yes.
So
So,
immediately convey the
yeah, what is your first step immediately about the heart or about the kidney?
about the kidney as the patient may develop acute kidney shutdown. So I will further evaluate. I can see that there's also dilatation of the proximal ureter and significant
Thank you,
hydronephrosis of the
doctor.
left kidneys.
Thank you so much. What happened?
Thank you.
She see something, mediastinal mass, and gave all possible differential diagnosis here. Okay? And then it was surprised really, because it's totally enhanced. Looks like cavity containing contrast, not just uptake of contrast. And there are a connection best seen in coronal ear with the left atrium. So this is aneurysmal dilatation of the left atrial appendage. Okay, but the examiner makes some trip for you here. The end of the film, look. Emergency down. Emergency is down. Marked hydrourethronephrosis. Marked. I don't know either this acute or chronic, but we should put our first action about the nephrostomy tube, or at least referring to the urologist. Then we will talk about our original finding, and we will insist, or we should tell the examiner that we are afraid from thromboembolic showering. What is the treatment for this aneurysmal dilatation, our doctor?
I guess surgical intervention,
Yes, excellent.
just
Surgical repair.
reduce.
It is resected because it is a source of embolic showering. Very serious. High risk for cerebrovascular stroke. Thank you, doctor, so much. The answer is
Thank you, sir.
here. Left atrial appendage aneurysm. Thank you so much. Next candidate. I think Dr. Amit joined.
Yes, I have told Dr. Mohan to
Yes,
go.
sir.
Yes.
I'm available actually.
Yeah, Dr. Mohan can go, then followed by Dr. Amit.
Yes, sir.
Okay. So this is 5-year-old patient presented with a headache.
Okay, sir.
Go on.
Okay.
Can you
I'm provided
request
with
can you request the control, but use the sidebar, please?
control. Mm,
Okay, I will scroll.
uh, okay,
I will
sir.
scroll
Yeah,
for you.
please. I'm provided with MRI brain. This is the flare sequence. I can see the normal fluid in the venous sinuses.
Yes.
Who is presenting? Is it hello?
Headache.
Okay. Uh,
Hmm. Go on.
yes, normal fluid seen, and I can see there is uh, some hyperintense signals in the walls of the transverse venous sinus on right side
Okay.
or adjacent to the transverse venous sinus.
Okay.
Mm, but the fluid is intact. Uh, Apart from
Yes.
that, I can see there is some effacement of the cystral spaces in the
Hmm.
perimesencephalic cistern
Yes.
on right side predominantly, and I can see some hyperintense signals in the middle head of hippocampus bilaterally. Yes, yes, the patient came with a history of headache. I can see there is hyperintense signals in the middle head of bilateral hippocampus. The cystral spaces appears effaced, and
Hmm.
some hyperintensity is seen in the cortical system, I guess.
Which sequence do you want?
Which sequence? I would like to see SWI. Okay. I want to look out any bleed is there in the cystal spaces or mm, mm, and There is no any blooming signal seen in the right
Are you sure?
transverse
Are you sure?
in SWI, there is no evidence of blooming in the right transverse sinus. So, can I go down, sir, little bit? Yeah. Mm,
What do you think?
um, uh, I think there is uh,
Yes.
there is I don't know, sir. Actually, there is some lesion, I guess, in the uh, right cerebellar hemisphere. I don't know because.
Look here in this slide, please. What do you think?
Mm, there is hyperintensity in the adjacent walls of dural venous sinuses, but
Okay, what else? What else?
the fluid is intact. But in the SWI, I can see there is no evidence of any blooming. If it was blooming, I would have thought of it as thrombus. Uh,
What else? Look at here. Look here, please.
oh yeah, yeah. I can see multiple linear fluids seen in the bilateral cerebellar hemispheres.
What does it mean for you?
Mm, that can be some AV malformation
What else?
or uh, can be
What
can
else?
be any uh, yeah, multiple vessels are there. Um, I think the dural venous is dilated, right side. Transverse is
At the
dilated.
left cerebellar hemisphere.
Sir, the cerebral
Look,
hemisphere, the right cerebral hemisphere appears atrophic.
left, left, not right.
Okay. Left
What is
cerebral
this?
hemisphere. I think that could be a developmental venous anomaly.
Yes. Okay.
Uh,
Could you have another look for the rest of the examination? Or
mm,
here, concentrate here, please. What happened?
yes, I think there is some abnormal communication between the venous and the arterial system here and in the basal system.
No.
Mm,
What else? Look outside the brain.
okay. Mhm. Mm, outside
Mm.
the brain. Mm, this is uh, a dilated subarachnoid space or
No.
an
Mhm.
arachnoid cyst.
Look at the right eye, please.
Mhm. Eyelid.
Right
Both
eye.
appears.
Right eye.
Yes, sir. Mhm. Both appears normal in size. I'm looking for any soft tissue abnormality in the orbit. Uh, I think the dilated vessels are there in the right orbit.
What is this?
There is um, I think maybe inflamed lacrimal gland.
No, no. Lacrimal gland in the soprolateral aspect.
Uh, uh,
So,
vessels.
yes. So,
Some
what's
abnormal
your
abnormal
diagnosis?
dilated vessel. Pardon, sir?
Okay. Yes. What's your diagnosis?
Abnormal communication. Maybe some dural venous sinus. Uh,
Abnormal communication between our vessels. What does it mean? Vascular malformation. List.
muscular. Yes, muscular malformation. Yes. Mm.
Vascular malformation. Okay. Thank you, doctor. What happened here, my colleague? There are two findings. One, one at the end of the film here, multiple DVA in the cerebellum, and the other
Okay.
one here in the left eye, intra and
Okay.
extra cranial
Mhm.
vascular anomaly. Okay, associated
Okay.
with marked dilatation of the left of the retron of the left sinus. So always orbital venous malformation and DVA.
Intra.
Okay, and the dural sinus malformation because the sinus is very dilated. Always don't satisfy of search. Okay,
Okay, sir.
next candidate.
Thank you. Thank you so
Next
much.
candidate. Okay,
Yes, sir.
yeah, welcome. My colleague take care. Nearly most of our cases has double pathology. Okay,
Yes, sir.
1 second. Doctor,
Yes,
this
sir.
is 25-year-old female patient with
Sir, your voice is breaking. I think my internet is a bit slow. Um, let
your voice is clear.
Okay.
Can you hear me well
So
now?
yeah, sir, your voice is breaking. But I can see the case. Like if you are scrolling, I can see it.
Okay.
Okay, so I've been provided with contrast and CT scan of the abdomen, arterial phase images. I see that there is a cystic lesion in the right kidney with some hyperdensity. Uh, so the images are jumping actually. So the images are
Yeah,
jumping.
I will change my connection. Would you request control, doctor, please?
Yes, sir. So can I scroll now?
Can you hear me well now?
Yeah, I can hear you. Hello? Hello?
Hello?
Yes, sir.
Yeah, you can
Yes,
Am I
you're
audible?
yes,
Okay,
yes,
okay,
you're audible. Yeah.
okay.
go on. Request control, please.
Yes, sir. Okay. So it's better that you control for me because I'm not able to scroll. Okay, so there is a
Okay.
complex cystic lesion in the right kidney.
I will scroll to you. Yeah, go on.
Yeah, yeah. The lesion appears to be solid cystic in nature. Um,
Yes.
yeah. So I'm concerned, but the lesion is not enhancing as compared to the renal cortex.
Okay.
Like, so it could be a complex cystic lesion or a cyst with hemorrhage, but there is no active bleed seen within the lesion.
So,
So this could be a complex cyst or a hemorrhagic cyst. Um, uh, and I'd like to see the other phases of the scan if they're available. Okay, so even on the delayed scan, uh, yeah, I can see some septations within the lesion. This is a cystic lesion with some septations and uh, some solid component, but I don't see any enhancing nodules within the lesion. So I believe this is a complex cystic lesion, but it does not appear to be a malignant lesion. Uh,
yes.
okay, so
So,
one of the septa is thickened and enhancing as well. This one uh,
mhm.
in the middle of the lesion. Uh,
Okay.
so this is a lesion of indeterminate, like this is an indeterminate lesion, and
See, what do you think? This is a non-contrast.
okay, so it is non-contrast CT. This lesion is hyperdense on non-contrast CT. So this is a hemorrhage within a cyst.
Yes. Yes. So don't
Yeah.
decide this is complex before
Okay.
comparing with the non-contrast. By the way, my
Right.
colleague, this is a common mistake for all of us. So what's your diagnosis and the classification for this cyst?
Okay. So this is a cyst with hemorrhage. The margins of the cyst appear to be smooth, and I don't see any like calcification within the cyst, and no enhancing septa
Yes,
are
what
noted
is
within the cyst.
your classification?
So I
What
think
is
this is
your,
a grade. I think this is a grade two cystic lesion uh, with hemorrhage.
what about this septum? See, the only enhanced one, this one.
So I think this could be a small vessel that is actively bleeding within the
No,
cyst.
no. Could the small
Okay.
vessel enhance less than the renal parenchyma?
No. Right.
So what's your final classification?
So I think, sir, this is a grade 2F kind of cyst. Um, and I think,
Do you think grade 2F has this six septum in the criteria? No, this is
so
six septum.
then this
Looks
could be
like
grade
more.
3. Yeah.
Yes, it looks like more than 2 mm. Okay,
Yes,
so
sir.
you must jump to grade 3. Okay,
Yes, sir.
if this one is a true solid, True solid component. What will be your classification?
So then it will be malignant, I think. It will be grade 4.
Yes. So, what is the name of this classification, doctor?
And Bosniak classification.
So, it is very important, my colleagues, and many of us confused between the different degrees of Wozniak. I will tell you something very easy. Okay, simple cyst is grade 1. Malignant cyst, malignant, what does it mean? Either
Sir,
enhancing nodule, solid component, or mass containing cystic necrosis. This is the malignant, grade 4. The
right, right,
confusion is between 2 and 3. Okay,
right,
when you see this sick enhanced septum, this is 3. Okay,
right,
when you doesn't see grade 1 or grade 3, whatever you see, you have seen, calcification, hemorrhage, okay, all of these are grade 2. At
grade
least,
2.
at
Right,
least you can remember all of them like this. Okay, my colleague.
right, sir.
There are many and
Yes,
many criteria, but at least keep the most common or the most guiding criteria in each one. Number 4 is the pure malignant. Number 1 is the pure benign. The confusion is between 2 and 3.
2 and
Thank you,
3.
doctor, so much.
Yes.
Yeah,
Thank you, sir.
thank you so much. It was, see here, even by the MRI. Look here.
Yes, so this hyperintense area appears to be the hemorrhage. Uh, and yeah, some septations are
See,
noted
see
in the
in,
lesion.
see in axial T1 pre-contrast, the same.
Yes, sir.
This is very contrast, okay? But the
Yes, sir.
enhancing lesion is more lower. 1 second.
Okay, right, right.
Look, here.
So
What
this is
should you do
enhancing
if you
tissue. This is
what
the enhancing
what
tissue.
should you do? What should you do if you still confused between T1 pre and the T1 post contrast?
Um,
Subtraction.
I'm confused.
Ask for
Subtraction. Okay,
subtraction. Okay.
okay,
Thank you so much.
right. Thank
Next
you, sir.
candidate. So my colleague, it was a Bosniak
Multi-operative.
grade 3. After biopsy, it was proven as multilocular cystic nephrom. By the way, we have two atypical, but I think a common picture of RCC. Number one, the hypoenhancing renal mass, which is not clear cell. It is a papillary type of HCT. Is very, I think, common. Number two, the multilocular cystic nephroma, or even cystic nephroma, which is the higher grading of Bosniak, starting from Bosniak 3 and then Bosniak 4. Take care even during, leave the mouse, please, doctor. Yeah. Take care, my colleague, even during our practice. Sometimes we didn't take care about the renal cysts. Some of them has second wall or septum or nodule or atypical hyperdensity. So it need more and more further examination, either by contrast or by MRI. Thank you so much.
Thank you, sir.
Next candidate.
Yes, sir, here.
I think it was one success. Can you see my screen, doctor?
Yes, sir.
Doctor, this 20-year-old female patient presented with headache, drowsy, Okay, and the tinnitus.
Okay, sir. Sir, can I ask for control?
Yes. 1 second.
Requested, sir.
Go on.
Okay. So I'm presented with the contrast enhanced CT, chest and upper abdomen. It is arterial phase study. I would like to scroll through the images first,
Yes.
and then I would like to comment about my findings. I can see that the contrast is normally opacifying bilateral pulmonary arteries, the carotid arch, as well as the carotid branches. There is normal enhancement of the bilateral thyroid glands. Okay, I am at the uppermost cut, so I would like to go back to the chest sections. Okay, so bilateral internal jugular veins appear normal. Uh, okay. So I can locate, I can see that there is no filling defect noted within the descending aorta. The heart is, the left atrium shows normal contrast opacification. I'm trying to look at the vessels which are reaching the periphery of the lungs, which appear unremarkable. There is a, okay. The interventricular septum appears normal. However, I can see that there is some. Okay, I would like to go back to the right atrium and the right ventricle.
Yes.
Okay, it is an artifact from the contrast. Okay. Okay, so now I'm going back to the upper abdomen, and I can see that the liver is showing a normal enhancement on this arterial phase. Both kidneys are enhancing normally. Okay, so at this level, just below the celiac bifurcation and at the origin of the SMA, I can see that there is peri-aortic soft tissue thickening, which extends down along the length of the aorta. And I see that it is causing luminal nerving of the aorta. And then again at the bifurcation, the bilateral common iliac arteries are bifurcating normally. So there is circumferential soft tissue thickening around the aorta, and it starts from the abdominal upper abdominal aorta at just below the celiac axis, and it goes up to the level of the aortic bifurcation. So these findings, I'm thinking about some baseline disorder in this patient, which might be vasculitis, and
Sound?
uh,
Sound.
for yes, sir.
What sounds? Hmm.
Sir, normally the vasculitis, which involves the aorta and its branches, is Takayasu's arteritis most commonly. So
Yes.
it is an auto, or yeah, sir, it is a autoimmune vasculitis, and it involves the aorta and its branches as well. Going in my first scroll, I could also see some thickening along the origin of the left subclavian artery. So right now I am thinking about that this might also be affecting the branches of the aorta as well. So for this, I'm trying to look for involvement of the renal arteries to exclude the possibility of other types of vasculitis, such as polyarteritis nodosa. I can see that both renal arteries are appearing normal, and there is no soft tissue thickening along them.
Do you think this is the correct association or differential diagnosis in large vessel arthritis to talk about polyarthritis nodosa?
No, sir, it is a small and medium-sized arteries. So
Yes,
that's why
sure.
I'm
So
just, yeah,
no,
I'm
no. See,
just,
see.
yeah,
Don't
yes.
don't include unlogic differential diagnosis. You are doing very well till this point. It is a
Okay, so, sir,
typical takayasu. So don't talk about any other irritating differential.
okay, sir. Okay. Sir, the other possibility could be of aortitis in this patient, but I can see that the flat fat planes are quite preserved. And for aortitis, it has to have some kind of inflammation ongoing in the body or some kind of infection, which might lead to that inflammation. But here I can see that it is a very well-defined circumferential soft tissue thickening. So I would like to defend my diagnosis of Takayasu's arthritis in this patient. I would also
Mm.
like to scan, I would also like to see if available the images of the brain involving the temporal arteries or just to exclude that it is affecting the intracranial vessels as well or not.
Okay. What other types of arthritis do you know?
Sir, sir, I know that there is, so one I have discussed is polyarthritis, and there
Nodosa.
is one, yeah, yes, sir. And
What else? Yes.
so I cannot recall exactly any other. Yes, sir. There is one which is Henoch, HSP vasculitis, Henoch Schönlein purpura, which is mostly noted in the kids, and then one is Kawasaki's disease, which is also vasculitis, which occurs after the viral infection, and it
Tell
also
me,
involves the
tell me,
yes.
tell me the name of the commonest, commonest disease that associated with aneurysmal dilation and thromboembolic disease.
Sir, aneurysmal dilatation and thromboembolic. Sir,
The
I
same
cannot.
disease.
Uh, sir, I cannot recall. Actually, the name has slipped from my mind.
This is very, very common to involve the pulmonary arteries
Yes, sir.
as oral and genital ulcers.
Yeah, sir, Bassett's. Bassett's. Yes, sir. Sir, I
Acid.
forgot actually. Yes, sir. I forgot the name actually. Yes.
Okay. Uh, how could you describe the affection of neurofibromatosis on the brain vessels?
Sir, it can also cause a type of vasculitis, and
No,
especially
it can cause um, a very common disease. Do you know the
yes, sir,
name?
Moyamoya disease. It causes Moyamoya disease.
Okay. What is the name of the vasculitis that affect mainly temporal artery?
Sir, which artery?
Temporal artery. Temporal.
Sir, it is temporal arteritis, which is
What is the name of disease that cause temporal arteritis? Okay.
sir, isn't it Takayasu's? It is the same, I think.
No. Very
No.
common disease in Japanese. Hmm. Giant
Yeah, okay.
cell arteritis.
Giant cell, yes, sir. Sorry.
What is the granulomatous disease that can very, very common to cause infarction, brain infarction?
Sir, you are asking with respect to the vasculitis or
Yeah, we are revising the chapter of vasculitis. This is the aim of this case.
sir,
Hmm. How
Is
many,
it
how many,
sarcoidosis?
no, how many granulomatous disease you know?
Oh,
TB is not common to cause
sir, I know TB,
vasculitis.
tuberculosis. Yes, sir.
Not TB, not sarcoidosis.
Okay.
The last one, syphilis.
Sir, I
Syphilis.
cannot. So which one? Syphilis?
Syphilis.
Okay.
Okay.
Okay. Okay.
Okay. Uh, do you need any vasculitis question? More of a question about vasculitis, or is enough? We just revise the points that not common or not familiar for all of us, but this is not mean that you must be asked like this in the exam. I just revise. Okay. By the way, my colleague, there are a median aortic syndrome also, and there are the arcuate ligament syndrome, and I'm talking about the abdomen, and there are nutcracker syndromes. All of this besides aortic dissection, I think this 7 or 10 diseases, I think this is the most common vascular related disease in the scope of our exam. Thank you, doctor, so much. You did very well. Here, my colleague, the answer was
Thank
Takayasu. Leave the mouse. Leave the mouse.
Okay, sir.
Takayasu fitting medium size and large vessels. Okay. So don't talk about anything else not related to the diagnosis. I think Takayasu, when you see it affecting the water its major branches, I think don't mention any other. Look here. Very narrow. Very narrow. Okay. If we do MRI, you will see the wall very thick. And this is the value of MRI. MRI, not just MRI with contrast, okay? With contrast. Not just showing you the lumen, either it's narrow or dilated, it can show also the wall itself, to how exciting it is affected. Okay. Also, my colleague take care, MRI neck must be done with contrast. Why? Because the blood velocity is so high that we cannot detect by time of light like intracranial vessels. Thank you so much, my colleagues. Thank you so much to our coordinator. Let's meet in another session. Goodbye.
Thank you, sir.